Imagine a patient walks into your clinic, say, 2 weeks post-facelift.
Oh, man.
Right. The skin is perfectly draped, the jawline is razor sharp, but the moment they smile, the right side of their mouth absolutely refuses to move.
Marginal mandibular nerve injury.
Exactly. Marginal mandibular. It's a surgeon's absolute worst nightmare. You are just staring at this devastating surgical complication. But, and this is the crazy part, what if you could essentially fix that devastating asymmetry in 60 seconds?
Just using a needle?
Yeah, a needle and just a few strategically placed units of neurotoxin.
See, that right there is the exact difference between treating neurotoxin as, a simple wrinkle eraser and understanding it as a profound modulator of facial mechanics.
It's a completely different mindset.
Completely. And for you, the resident or the attending listening to this deep dive today, our goal is to get you beyond just being a simple technician. We really want to master the functional anatomy and applied mechanics of chemodenervation.
Because it is a wild clinical reality. You spend years and years in residency mastering the finer points of, say, a rhinoplasty or a super complex microsurgical flap.
Right.
But you might get, maybe a single afternoon of formal training on neurotoxins?
If you're lucky.
Exactly. And yet, injections of botulinum toxin type A are literally the most frequently performed cosmetic procedure in the U.S. They easily outpace retidectomy, blepharoplasty, rhinoplasty, and liposuction combined.
It's staggering.
It really is. So to use this tool properly, you have to understand exactly what it does at a microscopic level. You're fundamentally altering a neural pathway.
Yeah, you really are. You cannot modulate a system until you understand the cellular machinery driving it.
Yeah.
So we're talking about a very specific 1,295 amino acid chain.
Which is massive.
It's huge. And structurally, it has a heavy chain and a light chain.
Yeah.
Now, the heavy chain is basically the vehicle, right? It binds directly to the neuronal cell membrane at the neuromuscular junction.
Just docks right on there.
Docks right on. And that binding is what allows the light chain, which is actually a zinc-dependent manila protease, to slip through the membrane and get right into the cytoplasm of the nerve terminal.
And that's where the magic happens.
Exactly. Once it's inside, it acts like a pair of biological scissors. It actively cleaves a very specific transport protein called SNAP25.
It's funny. I always have patients sitting in the chair who say, oh, I love when my muscles are paralyzed.
Oh, I hear that every day.
Right. But that is biologically inaccurate. I always tell my residents that calling it paralysis just gives the totally wrong mental model.
It does.
It's really more like we are just cutting the phone line between the nerve and the muscle. The muscle itself is perfectly fine.
That is a perfect way to visualize it. By cleaving SNA25, the toxin structurally prevents the transmitter vesicle, the little bubble containing acetylcholine, from ever docking and fusing with the cell membrane.
It just can't connect.
Right. So without that fusion event, acetylcholine never enters the synaptic cleft. What you create is a strict presynaptic neural blockade. It directly affects the nerve, it does not directly affect the muscle fibers, and it certainly doesn't affect the overlying skin.
The muscle just loses the signal.
Exactly. It just loses its chemical stimulus and goes dormant.
And understanding that exact mechanism is honestly the only way to explain the clinical timeline to patients. Because they see the visible aesthetic effects wear off in, about 3 to 6 months?
Usually, yeah, as the nerve terminals sprout those new temporary connections.
Right. But at the microscopic receptor level, it actually takes 6 to 7 months for all of those clinical effects to truly disappear and for that original neural pathway to completely rebuild and reset itself.
Yeah, and because we are dealing with a highly specific chemical blockade at the microscopic level, your formulation and your dosing logic, they must be incredibly precise.
You can't just guess.
No. The days of treating this like a generic commodity, just, pulling a vial off the shelf and injecting a standard amount, that has to end if you want consistent, top-tier surgical results.
Oh, absolutely. The formulations matter immensely. You mainly have type A, which includes your well-known brands like Botox, Dysport, and Xeomin. And then you have type B, which is Myoblock. But honestly, in standard aesthetic practice, we almost exclusively see type A.
We do. But here's a really good clinical pearl for your practice regarding type B. It acts on an entirely different target within that nerve terminal.
Oh, right, because it doesn't hit SNAP25.
Exactly. It does not cleave SNAP25. It acts on a different snare protein called synaptobrevin. And crucially, it also comes pre-mixed in a vial with a much lower pH of 5.6.
Which means it absolutely burns going in.
Oh, it stings a lot.
So I have to push back a little here. I mean, if it burns that badly due to the acidic pH, are patients actually tolerating that just for a routine cosmetic touch-up, or are we risking losing their trust the second we push the plunger?
Well, it hurts significantly more. And you are totally right. You do not use it for a routine touch-up. But it has a very specific physiological advantage.
The speed, right.
Yes. Because of how it binds, the onset of action is incredibly fast.
Mm.
We're talking usually within 24 hours.
Wow.
So in real life, you save type B for the patient who walks into your clinic in an absolute panic because they have a major social event, like a wedding or a gala, in exactly 2 days, and they need their glabella frozen immediately.
Ah, the emergency Botox.
Exactly. It is a highly specific tool for a highly specific scenario. You warn them about the sting, but they accept it for the speed.
That makes total sense. And that need for specificity brings up a huge issue I see everywhere in training clinics. Why is everyone always looking for a standard dose cheat sheet?
Oh, it drives me insane.
Right, you see these laminated cards floating around telling you exactly how many units to put in the corrugator or the frontalis. It drives me crazy.
Listen, having a standard dose for a muscle makes as much sense as having a standard amount of fat to remove in every single liposuction case.
Yes.
It completely ignores the anatomical reality of the patient sitting in front of you.
Right. You would never just blindly extract 400 cc's of fat from every abdomen just because a textbook diagram said so.
Yeah.
You assess the tissue.
Exactly. You have to evaluate the actual muscle mass. Men, for instance, typically require much higher doses because their sheer muscle density is so much greater.
The bulk is just there.
Yeah. If we look at the glabella, the median dose across a population might be, say, 17.5 units, but that's just a statistical median.
It's an average.
Right. Some petite female patients get a completely perfect result with just 5 units, but a heavily muscled male might need 30 or more. You are dosing the individual's unique anatomy. You're not treating a generic illustration.
And because that dosing is highly individualized, you have to analyze the patient's specific functional anatomy from the moment they walk into the room.
Always. Top down.
Exactly. Start from the top down. With the glabella, you cannot just inject the standard 5 points. You have to actually sit there and watch how they frown.
The frowning patterns tell you literally everything you need to know about their underlying vectors.
Yep.
Most people naturally bring their brows together and pull them down. But you have distinct horizontal frowners and you have vertical frowners. And that dynamic movement dictates your syringe placement entirely.
Right, because horizontal frowners do not actually need procerus injections.
They don't.
The procerus is a vertical muscle, right? It pulls down, which creates those horizontal lines across the nasal root. If a patient is just pulling their brows horizontally together without dropping the medial edge, injecting the procerus is just wasting product. You just skip it.
You skip it entirely.
Yeah.
But your vertical frowners need comprehensive multi-muscle coverage. You must hit the medial corrugator, the procerus, and importantly, the nasellus muscles.
Oh, the nasellus gets missed so often.
It really does. If you miss the nasellus in a strong vertical frowner, you leave this compensatory downward pull. The patient will still squint and pull down from the nasal bridge, which completely ruins that smooth aesthetic result you were aiming for.
Well, and if we follow that logic, treating the specific dynamic engine rather than just the visible symptom, that directly translates to how we handle the frontalis.
Absolutely.
This muscle is continuous across the forehead. A lot of those older anatomy sketches show a gap or an aponeurosis in the middle, but functionally, in most patients, there is muscle present, even in the midline.
And here is a common pitfall for junior injectors. Too many people chase the right times.
Oh, yeah.
They see a deep horizontal forehead line, and they inject directly into the wrinkle itself.
Which makes no sense mechanically.
None. You must inject the strongest portions of the muscle belly, not the skin crease. Ask the patient to raise and lower their brows aggressively, almost to the point of exhaustion. Find the dynamic engine of that movement and target the muscle mass.
I'll be honest, I have a healthy fear of the frontalis, especially in older patients.
You should.
If you over-denervate it, trying to erase every single line, you run into serious trouble. You get that perfectly smooth but completely artificial heavy look.
That frozen forehead.
Exactly. But worse, you can cause profound brow ptosis or even eyelid ptosis.
Especially in patients who are actively using their frontalis as an accessory eyelid elevator.
Right.
In real life, you'll see older patients with significant dermatocallusis or low-lying brows who rely entirely on that forehead tension just to see clearly.
They're holding their eyes open with their forehead?
Literally. So knocking out their frontalis completely takes away their visual field. They physically will not be able to open their eyes all the way. It is a functional disaster.
It's awful for the patient.
So always test their brow mobility and check for compensatory lifting before you ever touch the forehead.
And that delicate balance of the frontalis, it leads right into the complex push and pull of the periorbital area and the brow position. You aren't just paralyzing individual muscles, you're managing a highly dynamic system of levers and pulleys.
It all comes down to compensatory pull. Honestly, this is arguably the most core concept in advanced chemodenervation.
100%.
Unweakened muscle sections react to weakened ones by pulling harder. They literally increase their resting tone to make up for the deficit.
I see this constantly with the classic Mr. Spock look.
Oh, the Spock brow. Classic.
Right. A resident will inject the central frontalis too strongly, essentially taking out the middle elevator. The lateral frontalis realizes the center is weak and it just kicks into overdrive. The lateral brows peak so aggressively, making the patient look surprised or, villainous.
To manage the brow properly and avoid that, you have to know exactly what pulls it down. And there are actually 11 distinct muscle segments that depress the medial brow. Yeah, you have the procerus, the transverse and oblique heads of the corrugator, the depressor supercilii, the medial orbicularis oculi, and sometimes even the nasolaris gets involved.
It's a crowded neighborhood.
Very. So to lift the brow organically, you target those specific depressors, you release the anchor, and the forehead naturally floats up.
I have to admit, early in my training, the lateral orbicularis oculi terrified me.
Really?
Yeah, because everyone thinks of it just as the muscle for treating crow's feet, but it has this fascinating dual nature. It is doing two very different jobs on the lateral side of the eye. You want to chase those deep lateral right tides, but I was always paranoid about dropping the cheek. Where is the actual line of demarcation between softening the wrinkle and causing structural collapse?
Well, here's the critical clinical pearl for that exact fear. The upper lateral part of the orbicularis oculi depresses the brow, but the lower lateral part acts as a vital elevator for the cheek.
So injecting too low is just a structural nightmare.
It is the absolute danger zone. If you aggressively over-denervate that lower lateral section, trying to chase every last sun-damaged wrinkle, you inadvertently knock out the cheek elevator.
Oh, wow.
You cause immediate malar flattening. Sometimes you can even create a visible extra skin roll between the lower lid and the cheek. Or worse, you get that harsh deer in the headlights look because the lower lid physically drops and retracts without the muscle supporting it.
And to avoid that, you absolutely must create a gradient of motion. You inject the most dynamic active area of the muscle first with your primary dose, and then you use much smaller, micro injections radiating outward.
Feathering it out.
Right. You never want a frozen, completely dead block of muscle sitting right next to a hyperactive, fully functional muscle. The line of demarcation between the two looks incredibly harsh and surgically obvious.
Absolutely. So we've established that in the upper face, over-injecting or miscalculating your vectors causes aesthetic oddities like the Spock brow or the heavy eyelid.
Right.
But as we cross the jawline and move into the lower face and neck, the stakes change dramatically. In the lower face, mistakes ruin actual daily function. Speech, eating, oral competence, everything is suddenly on the line.
The functional anatomy down there is incredibly unforgiving. I mean, if we evaluate the nasolabial folds and smile dynamics, patients will frequently come in complaining about gummy smiles, wanting an easy fix.
You have to closely evaluate the levator labii superioris aliquae nasi.
The LLSAN.
The LSAN, exactly. It's a long, thin muscle, mainly responsible for creating the medial nasolabial fold and handling that final 3 to 4 millimeters of central upper lip elevation.
But you have to be so careful here, because if you inject it blindly, you completely alter their intrinsic smile pattern. You will convert a canine smile, where the central lip lifts the highest, into a Mona Lisa smile, where the oral commissures lift highest and the center stays flat.
Exactly. And if a patient already has a natural Mona Lisa smile, injecting this muscle creates a flat, heavy, elongated upper lip that looks completely unnatural.
Almost simian.
Yes, they will hate it.
Right.
This injection is specifically reserved for extreme canine smilers or those with highly prominent gummy smiles.
A great practical tip here, and I show my residents this all the time, is that you can actually preview this exact result for the patient before you ever pick up a syringe.
The Q-tip test.
Yes. Have them look in a handheld mirror. Take a simple cotton swab and manually push their central upper lip down 3 to 4 millimeters while they smile. Let them actually see the structural change to their smile dynamics. If they don't like it in the mirror, do not inject it.
It's such a simple but brilliant tool. Moving further down, though, to the perioral rhytides and the mentalis. The orbicularis oris is a true sphincter muscle. You need highly diffuse low-dose techniques here. We're talking 2 to 5 units per lip maximum.
Maximum.
You use a more dilute solution to allow for an even, gentle spread across the sphincter.
Because the margin for error is essentially zero, I mean, if you over-weaken the upper lip, they lose the ability to make plosive sounds. Their P's and B's get all muddy.
Right.
Then general speech articulation goes. Then they literally cannot hold liquids in their mouth without drooling. It is awful for the patient.
And with the mentalis, patients come in complaining of that unattractive, dimpled cobblestone chin when they speak or animate. To fix it, you must thread the needle superficially to the mentalis. Keep the needle bevel right under the skin.
Just barely in.
Exactly. You'll successfully smooth the chin dimpling, but you absolutely must preserve the deep mentalis muscle fibers. If you push deep and paralyze the deep mentalis, they completely lose lower lip elevation and oral competence.
Now, here is a counterintuitive concept that I absolutely love teaching. Injecting the depressor anguli oris, the DAO.
Oh, this is a great one.
When you inject this muscle, it actually serves to raise the lower lip. It sounds completely backward until you sit down and look at the functional vectors.
Because the DAO is a triangular muscle whose sole job is pulling the oral commissures straight down toward the jawline. By chemically denervating it, you release that downward anchor. The unopposed elevators of the midface then naturally lift the commissures up.
It's beautiful.
It drastically improves marionette lines and reduces the show of the lower teeth.
And it is surprisingly one of the safest lower face injections you can do. Even if you slightly over-inject it, it doesn't cause drooling or a major functional deficit. It just gives them a slightly more elevated, rested-looking lower lip.
But you still must inject it low, near the inferior border of the mandible. If you inject too high, trying to chase the marionette line itself, you will hit the lower orbicularis oris fibers, and that will absolutely cause oral incompetence. Stay low and lateral.
Always. Now, jumping to the neck, I see residents getting entirely too aggressive when treating platysmal bands.
Oh, yeah.
The fascial planes down there are highly unpredictable.
You have to keep your doses reasonable in the neck.
Yeah.
15 to 35 units total is typically sufficient.
Right.
There was an old paper circulating years ago advocating up to 250 units for the neck.
That's insane.
Do not do that. Massive doses drift through the fascial planes. They hit the deeper constrictor muscles and the salivary glands. You cause severe dysphagia and debilitating dry mouth.
And patient selection is everything with the neck. The ideal candidate is young, usually 35 to 45, with strong, hyperactive platysmal bands but minimal skin laxity.
Do not inject lax neck skin.
No point.
Even if you perfectly and completely paralyze the underlying platysmal band, the redundant skin is still going to hang there. You have accomplished absolutely nothing aesthetically.
Right.
You do, however, see great results in patients who had an aggressive submental fat removal procedure and now have visible stark bands showing through the thinned-out tissue. The toxin softens that harsh contour beautifully.
Which brings us back to the scenario we opened with. True mastery of chemodenervation isn't just about primary cosmetic improvement for wrinkles. It is an essential, absolute requirement for rescuing surgical complications.
It really is.
This is where the true surgeon-to-surgeon application really shines.
It's your ultimate salvage tool. Say you perform an endoscopic brow lift and you have an incomplete corrugator resection. The patient has an excessive downward muscle pull in the early postoperative period that is threatening your fixation.
You treat it aggressively with toxin to neutralize that vector and maintain your surgical brow elevation while things heal.
Exactly. Or, you place a silicone chin implant and the mentalis disinserts or gets stretched, causing severe dimpling or unnatural tension over the implant.
Which looks terrible.
Right. So you relax it with a superficial injection to hide the hardware outline.
Or a patient has a submuscular breast augmentation, and the pectoralis major goes into a prolonged, intensely painful spasm because it's been stretched over the implant. You can inject the spasming portion of the muscle directly to break the cycle of pain.
It's a lifesaver.
And what about that nightmare nerve injury we talked about in the beginning, the marginal mandibular nerve?
This is a total game changer for your practice.
Yeah.
If you have a marginal mandibular nerve injury after a facelift, the affected side of the lower lip simply won't pull down. The face looks wildly asymmetric the moment they smile or speak.
It's glaring.
So what do? You inject the DAO on the contralateral healthy side to deliberately weaken it. You mask the injury by making the healthy side perfectly match the injured side while you wait those excruciating months for the nerve to recover.
It's brilliant. It buys you and the patient time. Now, before we wrap up, I want to touch briefly on hyperhidrosis, sweating in the palms, soles, and axillae, because it's a very different application of the exact same molecule.
Very different. The key point here, especially when you are treating the hands and feet, is depth control. The injection must be strictly intradermal.
Certainly.
Remember the local anatomy, the hand lacks the thick protective fascial barriers you have in other areas. If you drift deep into the subcutaneous tissue or penetrate the muscle layer in the palmar hand, the toxin will diffuse directly into the lumbricals and the arm muscles.
Then that's bad.
Very bad. You cause catastrophic weakness of the intrinsic hand muscles. They physically won't be able to turn a key in a door or grip a pen. Keep it superficial.
A single millimeter makes the difference between curing their sweat and ruining their grip.
Exactly. Millimeters matter.
Well, let's rapidly synthesize what we covered today. Success with neurotoxins isn't about memorizing arbitrary units from a laminated cheat sheet. It is about observing the individual functional anatomy sitting right in front of you.
It's respecting the reality of compensatory muscle pull. When you turn one lever off, another lever pulls harder to make up the difference. Your goal is selective weakening, the careful modulation of resting tone, rather than total unthinking paralysis.
It's all about applied mechanics. And as our understanding of compensatory muscle dynamics becomes perfectly predictable, it really makes you wonder, how close are we to a future where we use highly targeted asymmetric neurotoxin gradients, not just to smooth out wrinkles, but to completely replace the scalpel for early structural facial reshaping?